Yeah, we so all know that acute chemical injury is an ocular emergency and can cause significant morbidity. Well, first step would be when you have a patient with an acute chemical injury to classify or grade the injury with which the patient has presented. A white eye is an ominous sign in these patients. The next or the primary aim of treatment is to promote epithelialization in these patients, to support the repair and minimize ulceration, to control inflammation and the intraocular pressure. The first step again in this would be irrigation. First thing you need to do is get rid of the offending agent. It should be immediate, it should be copious, make sure that you've everted the lids. You could use anything that is available. It could be a tap water or a balanced salt solution in hospital settings, and do check the pH at the end. Give a break of at least 5 to 10 minutes before you check the pH after the wash. What you don't need to do is delay. Don't have to wait for any amphoteric solutions or phosphate buffers, and do not irrigate for anything less than 30 minutes. What is important here is to remember that a prompt irrigation is more important than the choice of irrigating fluid. Once we have done that, the medical management would include a broad spectrum antibiotic, because most of these patients would have some epithelial defect, cycloplegic to take care of the spasm. They do have significant inflammation for which you would need to start them on topical steroids. Take care of the intraocular pressure. Most of them would have a high intraocular pressure and would require lowering agents. Very rarely these patients can also have a significant hypotony and would require systemic steroids to be given. Lubrication to facilitate epithelial healing, either a bandage contact lens, patching or a tarsorrhaphy. And to prevent stromal melt, we would give topical citrate or a systemic tetracycline, which would act as calcium chelators and prevent collagenolysis, or a systemic ascorbate to further assist collagen synthesis. What you don't need to do, what you need to remember is, don't forget your topical steroids. Topical steroids are not contraindicated in acute chemical injury. In fact, you need to give them to control inflammation, and don't forget the intraocular pressure management. So once you have done with the irrigation, if you still have some foreign particles or offending agent left behind, most commonly the lime particle which precipitates, you could use 0.1 molar EDTA. Or if it is a larger plaque, it would require a surgical removal. The next step is facilitating epithelialization. You would prefer that the patient, the epithelium heals faster, so that he does not land up with something called as a persistent epithelial defect, which might result in a stromal melt or perforation. You need to avoid patient landing into a stromal melt. So what you need to do is control inflammation, look for factors which could inhibit epithelialization, like ischemia, total loss of epithelial cells, or an exposure. So don't stop steroids. Steroids do not interfere with epithelial healing. The concern is either a secondary infection or a stromal melt, which should be taken care of. Do not stop with one intervention. These are not patients where you do one amniotic membrane transplant and you would be happy sitting that, okay, if it is not healed, now I don't know what to do. They might require multiple surgical interventions, multiple amniotics, and do not hesitate to refer to a higher center. If you have a corneal and a small conjunctival defect, go ahead with an amniotic membrane transplant. Again, you might need a repeat amniotic sometimes in these patients. However, if there is an associated scleral ischemia, you would have to cover that ischemic area with a tenonplasty or a vascular bed, so that the epithelial cells migrate over it and the surface gets epithelized. However, if you have something like a grade 4 and more of Dua's classification, where there is a complete loss of epithelium from the surface, so from tarsal to tarsal you have no epithelium, in such patients, to facilitate epithelialization, you would have to provide an external source of epithelium. It could either be your oral mucosa, or the easiest is to get hold of a cadaveric limbus, that is an allo slit, as was done in this patient, to facilitate epithelialization. The next most important thing to manage epithelialization is to take care of exposure. Sometimes because of the injury, the lids get scarred, and these patients either have an incomplete blink, or there is a total loss of blink resulting in a lag ophthalmos or a complete exposure, and the patient can present to you with a melt. So a simple procedure like tarsorrhaphy can prevent these complications. So the acute phase is all about managing your eyes and the E's. So the inciting agent, inflammation, ischemia, intraocular pressure, exposure and epithelial defect. We have recently published, which has now been accepted in the Ocular Surface, a review article on the algorithm approach to management of acute chemical injury, where these I's and E's have been summarized well in this table. To summarize, acute phase management is crucial. You need to manage your I's and the E's. You need to anticipate complications, and these are patients who would require a close follow-up. Thank you.
Thank you.